My name is Alin Barrera, and I'm one of the 2020 board members, and I have the honor to introduce our moderator for our next panel. Stephanie Teleki is CHCF's Director of Learning and Impact. She partners with the Foundation's program teams to support organizational learning, evaluate the Foundation's investments, and optimize impact. Stephanie also leads the Foundation's portfolio in maternity care as part of CHCF's focus on high-value care. Prior to joining CHCF, Stephanie held various positions in research and management, including serving as a policy analyst at the RAND Corporation, where she conducted health policy research and evaluations for such clients as the Agency for Healthcare Research and Quality, the Centers for Medicare and Medicaid Services, and much more, I'm sure. So please welcome Stephanie.
Hi there, and thanks for hanging in there. I know we have the kind of after lunch slump spot, and we've got a fairly wonky topic, so we're going to try to keep it interesting. I will say, and I know I'm biased, I think this is one of the most important topics, and I think it gets, as a funder who funds in this space of measurement, when people ask me what I'm funding and I start talking about this work and I get excited about it and eyes glaze over and people start looking at their phone, and this can be in the weeds topic, and I'm going to present today that it's fundamental to everything else that I think we're trying to do. So I hope you'll stay awake with us for the next hour. We do have a really all-star lineup here, and I want to introduce each of the speakers. This is going to be a little bit more traditional kind of panel setup today. Each of them are going to come up and present, and then we'll have a conversation afterwards and take as many questions as we can. So to my immediate left, we have Christine Rinki, who is an applied maternal and child health epidemiologist and the California MIHA Survey Project Manager, and she will tell you all about MIHA in a minute, with the Center for Health Equity at the University of California, San Francisco. And I'm going to keep these intros short so we have more time. Their bios are on the website. Next, we have Carol Sakala, who leads maternal health and maternity care programming at the National Partnership for Women and Families in Washington, D.C. She has importantly been the investigator on all of the national Listening to Mothers surveys and was the lead for the Listening to Mothers in California survey. And she also, importantly for this topic, co-chairs the National Quality Forum Committee that recommends performance measures for national endorsement. And lastly, we have Sepheen Byron, who is the Assistant Vice President for Performance Measurement at NCQA, the National Committee for Quality Assurance. She leads measurement activities in the areas of preventive services, Medicaid, and pediatric and maternal health care. So I'm very proud to say that all of these three fantastic women are grantees of the California Healthcare Foundation, and the work that they're going to talk about today is work that we have helped to fund along with a couple other co-funders, the Zoma Foundation that's been represented here, and the Yellow Chair Foundation, and also federal and other state dollars. So some people wonder sort of what's a nice funder like me doing in a place like this with a measurement topic, and so I wanted to spend a minute just telling you a little bit about who the California Healthcare Foundation is by way of introduction. So we're an independent nonprofit philanthropy based in Oakland. We give away about $30 million a year. Our maternity portfolio is about $2 million, and we focus on maternal mental health right now and birth equity for Black mothers. We've had other topics that we've focused on for various years before, but those are our topics of focus now. We focus on California and especially the Medicaid population, or Medi-Cal as we call it. We strongly believe in measurement as a really important underpinning to our work. So sort of why is that? Why are we investing heavily in this topic? Well, as many know, and people have thrown these statistics out, but the fact that so many women experience symptoms but are not officially diagnosed, and then if they are actually diagnosed, they don't receive treatment. So that's the sort of problem that we're trying to deal with, both from a prevention standpoint and from a healthcare system standpoint. And we know that it's concerning, and I know I'm preaching to the choir here, here, but we know that there's high prevalence of these conditions, especially in underserved communities and low-income communities. We know that the disorders are associated with negative outcomes for the mother, the family, the child. We know that they cost a lot. We just heard about that earlier today with the Mathematica study. And importantly, and really tragically, we know how to treat a lot of these conditions, and we're not doing it. And so that is, the measurement world is about trying to understand what we're doing, what sort of how we're doing, and then try to figure out how do we fix it. So sort of how are we going to solve this problem? This is a quote from Peter Drucker, who's a sort of business management guru. Probably some of you have heard of him. And he famously said, and it's repeated over and over again, that if you can't measure it, you can't improve it. And that's really the point here. If we have no idea how we're doing at a societal level, at a state level, county level, et cetera, how in the world are we going to know what to do? And how are we going to know if what we're doing even matters or is sort of having any impact at all? So very simplistically, in the philanthropy world that I live in, we think a lot about what philanthropy can do, what any of us can do, and kind of what are the different levers for change. And so this is a very simplistic, you could add a lot more levers, but it's sort of what we're trying to do is in the middle, and our different levers that we can pull is circling around. And I would argue that the transparency, kind of monitoring data, information, metrics, whatever words you want to use to describe there, and I don't want to get hung up on the sort of words that we use, but the sort of information piece in the orange box really underpins every other lever. We can't attach payment to the desired outcomes if we have no idea how we're doing or what people are doing. We can't make good policies without good information. We can't engage consumers around the topic and let them know sort of how different providers are doing that may influence where they want to get care. And we can't improve quality without knowing where we're starting and seeing if we're getting there with what we're doing. So it really is the basis for so many things. And I kind of listed off some here. I'm not going to read through this slide, but these are all the ways, and I just kind of covered some of them in the prior slide, of how measurement, data, indicators, measures, whatever you want to call them, how the information can be used to help further maternal mental health in this case. And really, without reliable, valid measures that are importantly trusted by the people who are being measured, and that's a really important part of this, we can't make progress on any of the other things that we talked about, I think, during this conference, in my opinion. Now I'm going to do something crazy, which is like take the entire field of healthcare quality measurement and try to condense it into like 30 seconds. But just as background, and kind of in the orange at the bottom of this slide, there is the underpinning of sort of surveillance, public health, general sort of how are we doing writ large, big picture, 30,000-foot level. That underpins everything, and that's sort of the North Star, if you will, and both Christine and Carol will be talking to us some about the measurement work that they have done in that space. And then sort of in the delivery system, which is where CHCF funds and where kind of the rubber meets the road, if we haven't done a good job on prevention, is what are we doing in the healthcare system to address the different issues that are coming up. And for there's a famous model, Donabedian, structure, process, and outcome measures that we try to look at in the healthcare system. And by structure, we mean how care is organized, big picture things, how many hospitals in a healthcare system, how many behavioral health providers do you have, so really kind of counting type of measures and bigger picture. Those are kind of the least satisfying for a lot of what we do, but super important, and obviously the number of behavioral health care providers is critically important. So that's important to keep your eye on. Then there are process measures, which are sort of what is done. Did a woman get screened? Did a mother show up at her postpartum appointment? Those kind of things. And those can be extremely helpful in sort of directionally letting us know how we're going if we're tracking things that we know hopefully are associated with outcomes. And then lastly, outcomes, which are the holy grail, which is, rubber meets the road. How is the patient doing, and how did they experience the care? And those are sort of the key kind of categories of quality metrics when you're talking about in the healthcare system. Again, sort of very crudely, the talks that you're going to hear today kind of touch on some of these different things, and Carol and Christine are really coming at it from a higher level 30,000 foot or a little bit lower, but not necessarily deep in the system in terms of what they're reporting on, and are doing that from patient self-report, from surveys. Whereas Sepheen, who will go last, is talking about sort of in the delivery system at the health plan level, how can we really track what things are going on. So I would just end my little opening remarks by saying, I think the key points here just to take away from this, and really always looking for partners in this space, are it's really hard work. These are hundreds of thousands of dollars of efforts to collect data that are, you're going to hear about today. It's hard work financially to get the funding to do this work and to continue it, and also to actually do the work, get the response rates, all of those kind of things. Nothing is perfect. You can criticize every measure that you're going to hear about and every indicator up here. We're doing the best we can with the funding that we have to get a window into how we're doing. Getting to individual level outcomes, which is really what we care most about. How are women, how are people experiencing care is very, very hard. It's very expensive, and we are still trying to figure out the data infrastructures to do it well. And that we need both. We need the surveillance, high-level measures, and we need the deep in the system measures. We need both of those things, and we need to keep our eyes on both of them to be able to sort of understand, again, where we are, how we're doing, and where we're going to hopefully go. So with that, I want to turn it over to Christine to come on up and take it away.
Good afternoon. Thank you all for showing up this afternoon and being here for this amazing two-day conference. I'm really honored to be here. It's the first time that I've attended, and it's really powerful to be in this space. So thank you very much for joining me in it. And so today I'm going to talk to you a little bit about the expansion of the measures that we have included in the maternal mental health measures that we've included in the MIHA survey, and to share with you some of the results of our prior work. So what is MIHA? It stands for the Maternal and Infant Health Assessment, which is California's annual postpartum survey. If you're not from California, you might be familiar with PRAMS, which is a postpartum survey implemented in many other states across the nation in partnership with the CDC. But like many things, California goes its own way, and we have MIHA. MIHA is led by the California Department of Public Health, the divisions of Maternal, Child, and Adolescent Health, and WIC, and is implemented by the University of California, San Francisco Center for Health Equity. And MIHA collects otherwise unavailable data that is used to guide program development and policy advancement. So each year, we sample women using a stratified random sample from live birth certificates of California resident women. We invite women to participate in the survey by mailing them a paper and pencil survey, old school style. And for those who do not complete those surveys, we invite them to complete the questionnaire over the phone in an interview or online through a web-based survey. We currently implement the survey in English and Spanish, but not in any other languages. The survey, as Stephanie mentioned, collects self-reported information from women. And we have a number of mental health measures, which I'll talk about today. But one of the things that we really focus on and really pride ourselves on is collecting information about the social and economic factors that really do drive many of the health outcomes that we see. And we're one of the unique sources to be able to make those connections and be able to draw some of those conclusions and establish an evidence base in that area. Annually, we have about 6,000 to 7,000 women who participate in the survey, and in recent years, our response rates have been just above 60%. We release data on a regular basis at the statewide, regional, and county levels. So next, I'd like to share with you the measures that we currently have on the MIHA survey related to maternal mental health. So that arrow looked different on my computer. but that's okay. So we ask women if they have a history of depression diagnosis prior to the current pregnancy that we're asking about. And we also assess whether women have depression or anxiety symptoms using a PHQ-based 4-question series that's been adapted for a retrospective postpartum survey. We ask this during pregnancy, and we also have a second series of questions that we ask postpartum. So using the PHQ-4, we have been able, with funding from the California Healthcare Foundation, to build upon our long-standing PHQ-2-based questions on depression to add a GAD-2, generalized anxiety disorder, 2-item ultra-brief screener, to get at anxiety symptoms, which we haven't been able to have at the population level in California. And then together, collectively, the PHQ-4 gives us a valid measure of psychological distress. So we do think that while these are very brief measures, they are going to be a great advancement to what we have been able to say about what is the percentage of women who are experiencing this statewide in California. Also, with funding from California Healthcare Foundation, we've recently added a question asking women whether they received screening for depression or anxiety symptoms during their pregnancy or postpartum. So we ask them whether it occurred during pregnancy and also whether it occurred postpartum. So we are, again, I'm glad you're feeling safe. Thank you. Whether we're able to, this is a process measure. It's a population-based process measure that will allow us to do apples-to-apples comparisons across women who are in any number or no healthcare delivery systems. So this is going to be something that I think is going to be very powerful. In 2018, we added a 3-question series on whether women felt they had a need for help related to emotional well-being or mental health concerns, whether they received counseling or treatment when they felt those needs, and what were their reasons for not getting emotional or mental health counseling or treatment in those circumstances. We have not yet released those data. We've just completed enough data collection to be able to dig into analysis. And again, support from the California Healthcare Foundation is going to allow us to do some really deep dive there and have a nice report on that. So we're looking forward to sharing that information, and maybe we'll be able to talk about it next year. So next, I'm going to share with you some of the results of some of our prior work. And as Stephanie said, this is really to give us that high-level evidence base for where we're at in California. Some of this, I think, will validate information that we already know, and will also perhaps provide a little bit of evidence to back up what we see in practice or in our lives and in our communities. So we'll just start out here. This is data coming from 2013 through 15 in MIHA, and 20% of women in California with a live birth are experiencing symptoms of depression either during pregnancy or in the postpartum. In California, that translates to 100,000 women a year. And MIHA also show that symptoms of depression vary by race, ethnicity, and by income. And these charts show the percentage of women with a recent live birth who experienced symptoms of depression. The red bars show the percentage of women who experience these symptoms during pregnancy, and blue bars show those symptoms postpartum. And while approximately 20% of Black and Latina women experience these symptoms during pregnancy, we see that compares to only about 10% of Asian or Pacific Islander women or white women. And then if we look at the chart on the right, we see that as income increases, the symptoms of depression decrease. And what we know also is that these women who are experiencing these higher prevalences are also the least likely to be able to be accessing services in response to them accessing the treatment they need to feel better. And as the numbers of hardships that women experience increase, so do depressive symptoms. And this is true about the hardships she may have experienced during her childhood, as well as pregnancy stressors. So I'll unpack this a little bit. So among women who reported none of the hardships that we measured during her own childhood, only about 10% of women in that group experienced symptoms of depression during and after pregnancy, compared to 25% of women who reported 4 or more of the childhood hardships, or ACEs, that we measured in our survey. The pattern is also true and more stark for pregnancy stressors. So among women with no stressors that we measured during pregnancy, for them, only about 8% experienced symptoms of depression. But among the women who reported 4 or more of the stressors that we measured, which includes really significant stressors, homelessness or housing instability, intimate partner violence, food insecurity, divorce or separation during her pregnancy, we see that 1 in 2 of those women who are experiencing 4 or more hardships are reporting symptoms of depression during or after pregnancy. And so while today and yesterday and in our daily work, we really focus on the very important activities of screening women, referring them to care, and getting them into treatment, what we can see is that in order to prevent these symptoms from arising, to prevent maternal depression, we really do need to start thinking about upstream through the life course and upstream in the social and economic systems in which women live. So those interventions that focus on healthy relationships, economic security, housing security, addressing racism in our communities and in our structures, those are the kinds of things that can really show marked change and bring down the prevalence of depression for women who are giving birth in California. And so I think there's a place for bringing this work together. And it's also really important to note that the slide I just showed the disparities we also see by race, ethnicity, and income. And while hardships occur to women in any walk of life, in any economic strata, we also know that Black and Latino women are experiencing these hardships at a much greater rate, and that women with lower incomes are also at more risk of experiencing these systems because they are part of the structure of our society. So finally, bringing us back a little bit closer to the conversation around screening and treatment, depression during pregnancy is a leading risk factor for postpartum depression. We know this from the literature. I just wanted to show a little bit of California data to kind of illustrate this point. What we see is that women who experienced prenatal depression symptoms, 50% of them went on to experience depression symptoms postpartum. But among women with no prenatal depression symptoms, only 7% went on to experience symptoms of depression in the postpartum period. So this is really evidence that shows us that screening needs to start early and needs to occur often during pregnancy. So finally, I'd like to acknowledge the funders of our work and the California Department of Public Health, particularly the Maternal, Child, and Adolescent Health Division, which has really been a leader in guiding this work with Title V federal block grant funding, and of course CHCF. And also, really importantly, the birthing individuals who participate in MIHA every year, many thousands of women who take the time to share their experiences with us and help us understand what's going on for women in our communities. So if you're interested in reaching out, here's some contact information. We'd love to hear from you. So now Carol's going to take a deeper dive.
So, good afternoon. I'm really excited to be able to contribute to this discussion with some of the things that we've learned from our Listening to Mothers surveys. And very briefly about the National Partnership for Women and Families, we work for a just and equitable society in which all women and families can live with dignity, respect, and security. And we do that through 3 different program areas that are very interrelated: access to quality, affordable health care, reproductive health and rights, and economic security. So today, I just have time to share some of the highlights of what we've learned from our surveys that we've carried out since 2002. And the final slide gives you information for learning more if you'd like to go further. And of course, you're welcome to contact me as well. So It's been a great privilege to give voice to those who care most about maternal health and maternity care mothers themselves. And the important thing to know about our methodology is that we work to provide population-based information. So if it's a national survey, we attempt to describe what's going on in the nation as a whole or for subgroups in the nation, and similarly at the state level as well. And we cover a very large range of topics from before pregnancy to well into the postpartum period. To date, we've carried out one state-level survey, Listening to Mothers in California, our most recent survey, and 3 national surveys. And for the second and third national survey, we were able to go back to the women who participated in the initial survey with a second questionnaire. So we have very rich data sets, and we're able to pursue mental health over time as well. So you've heard about MIHA, and we did, both of us did a 2016 survey of women in California. And I'd like to just compare and contrast those surveys. In general, our focus tends to be more on the maternity care side of things, and MIHA tends to focus more on public health issues. But this is, of course, a topic that spans both of those. We are jealous that MIHA gets to go annually. We can only give surveys when we have money to do it. So they're kind of irregular, but happy to do them when we can. And lastly, we have not paper-based, but all of our surveys are computer programmed, and that allows us to drill down into topics, cover a broad range of surveys with a single survey. Broad range of topics with a single survey. I'd like to give credit to my co-investigators on all of our surveys, Jean DeClercq and Maureen Corey. And thanks also to the MIHA team at UCSF, which helped us do the state-level survey because there were so many issues that were relevant at the state level that they had already tackled admirably. The state agencies were fabulous, and lastly, thanks to our generous funders, California Healthcare Foundation and Yellow Chair Foundation. So all of our surveys have included validated mental health screeners, and it's really important to note that a positive screen is not a diagnosis. That would require the assessment of a qualified practitioner. The conditions we've been able to look at include prenatal and postpartum depression, prenatal and postpartum anxiety, and post-traumatic stress disorder after birth, as well as various other questions related to these topics. So turning to our results, the first National Listening to Mothers survey, women participated up to 24 months postpartum. So that was a really interesting opportunity to look at their rates of screening positive for postpartum depression over 6-month increments out from the birth. We used the Edinburgh Postnatal Depression Scale, and we found that 19% overall who screened positive had not consulted a professional with mental health for mental health concerns, but 43% who scored 13 or higher and screened positive had done so. And overall, 19% screened positive for postpartum depression. So here you can see the results in 6-month increments. Pretty high for the first 6 months, dropping over the next year, but still quite high. And by 2 years, still very high. So this raises a question of whether we're talking about postpartum, perinatal, mental health issues, or something a little more related to women of reproductive age and those kinds of issues. And also I include one quote here just to say that we always collect open-ended comments from women that bring the data and the numbers to life. So our second Listening to Mothers survey, the first questionnaire, we included the PDSS, postpartum depression screening scale. This has a very inclusive cut point that is intended to pick up women who are experiencing minor and major depressive symptoms. And with that focus, we had 63% of all of our participants who screened positive. The reason we were really interested in using this is because it includes 7 subscales that look at different dimensions of postpartum depression. So if you look at the 2 columns on the right, you'll see the percentages of all of our participants who agreed or strongly agreed that in the past 2 weeks they were experiencing these various dimensions. So a very high rate said, I had shifting emotions, I experienced sleep disturbance, I felt some anxiety about my baby, all the way down to had suicidal thoughts, the lowest numbers, but still that's 1 in every 20 participant in the last 2 weeks before the survey. So the second survey, the second questionnaire, we included a version of the PTSD screening scale, PSS, that a researcher named Susan Ayers had validated, adapted and validated for post-traumatic stress disorder after childbirth. So the questions are asked with reference to the maternity experience. And this was a real eye-opener for us because 18% of the participants in our survey appeared to be experiencing some PTSD symptoms after birth, and 9% appeared to meet all of the DSM-IV criteria. That tool tried to pick those up. So that's something that we think needs more attention. And here you can see that the distribution of screening positive for all the criteria was very uneven across the participants. So Black women were somewhat more frequent in screening positive than white and Hispanic women. Younger women were much more likely to screen positive for all PTSD criteria than older women. Women with Medicaid much higher than privately insured women. And if the woman had screened positive for depression in the first survey, she was much more likely to screen positive for PTSD. So moving to the Listening to Mothers in California survey, we were delighted to be able to offer this survey in English or Spanish, and we used the PHQ-4, which, as you heard, has 2 subscales of ultra-brief questions to look at both depression and anxiety. And together, these are considered to be a marker for the severity of psychological distress. It was designed to look at the 2 weeks preceding the questions. We called on recall to ask as well earlier in the survey whether during your recent pregnancy you had experienced the various questions. And we had related questions as well in the survey. So 11% screened positive for pregnancy, for depression during pregnancy, and 7% screened positive for depression in the postpartum period. With respect to anxiety, 21% screened positive during pregnancy and 11% in the 2 weeks before completing the survey in the postpartum period. We also had high to low gradients that for both conditions by race and ethnicity and by type of payer. So prenatally, they went from most frequent with Black mothers, then Latina mothers, white mothers, Asian and Pacific Islander mothers, and with, again, with type of payer, Medi-Cal moms were higher than privately insured moms. Postpartum, there was less of a spread, but again, it was the Black moms who were most likely to have positive screens for both conditions. And that is something that we found over and over across many items in our survey. Alarmingly, just 1 woman in 5 with positive screens for either condition told us that during pregnancy, positive prenatal screens told us that during pregnancy she had received counseling or treatment for mental health, and just 1 in 3 with positive screens during the postpartum period told us that. So turning to some of the takeaways from our work, first, population-based surveys suggest the extent of maternal mental health conditions in the population, the extent of help receiving, and are important guides to policy practice, advocacy, research, many other types of responses. Postpartum depression, and I think we've seen that here in the comments from the podium, is most recognized and the biggest focus, most salient. But our results suggest that anxiety may be more frequent in both the prenatal period and the postpartum period, and also that both conditions may be more frequent during pregnancy than after birth. So we conclude from the prevalence of these conditions that screening and evaluation and access to treatment as needed for both conditions should be universal in pregnancy and after birth, and we urgently need nationally endorsed performance measures for perinatal anxiety and depression to foster this transition to widespread appropriate responses. Also, PTSD after birth warrants greater attention than it is getting. And lastly, regular population-based surveys to understand all kinds of things about the childbearing experience really are important. So here's my contact information. Please feel free to be in touch. And if you'd like to learn more, we have this slide for your guidance. And now I'll turn it over to Sepheen.
All right, thank you, Carol. See if we can get this going. All right, well, thanks for being here to talk about data and measures. I'm a data nerd. I didn't realize how much that emanated until one day my daughter, who was then 4, emerged from the coat closet wearing my hat and my scarf, my heels, and had my work bag slung over her shoulder. And she went, "Hi, I'm Sepheen. What are we going to do with all this data?" And I thought, wow, you picked up on that at the age of 4. It's really obvious. Okay, but I'm hoping I can make everyone else really excited about data as well. So I'm from NCQA. We develop measures. We are a national nonprofit based in DC, and our mission is to improve the quality of healthcare. And we actually are celebrating our 30th anniversary, and we really believe in measurement. It's full of data nerds like me. We believe that healthcare operates in the dark if you don't measure it. And if you measure it, you have transparency, and then you can push for accountability. You can tell people that this is what you're supposed to be doing, and you're not doing it, and we can show you the data that says you're not. So where do we fit in the quality landscape? Because there's a lot going on. You hear a lot about organizations, quality. I think in the very beginning, you have evidence development. That's where we have, the hardworking researchers, like those producing the Mathematica report to say that this is, what we need to do to have good care. And then you have guideline developers like the U.S. Preventive Services Task Force and physician societies or clinician societies that say this is how we can bring about good care and put that evidence into practice. So here's where NCQA sits, and this is in the measure development round. We take that information, take those guidelines, and operationalize it into a measure. So we say that the guidelines say women should be getting screened for depression. And so we're going to develop a measure that says, among your women, did you screen them? And we'll talk more about that. Measures endorsement you may have heard about, the National Quality Forum. Carol is involved in this, others, and I think in this audience. These are folks who put a stamp of approval on measures and say, we have evaluated these with our process to say that they're valid and reliable, et cetera. And then you have measure implementers. And here again, you have NCQA. So not only do we develop measures, but we also use them in our accountability programs. And we think that's really important because it is important to measure, but it is also important to hold people accountable for the results. So I'm going to be telling you about 2 HEDIS measures that we developed. And what is HEDIS? It's the Healthcare Effectiveness Data and Information Set. It's a tool used by over 90% of America's health plans, and it's used to compare those health plans on important dimensions of care. And you can see that we've got over 190 million people who are in HEDIS reporting plans. Just some examples of HEDIS measures. They actually run a full range. They look at preventive care. So an example here, cervical cancer screening, right? That's recommended for women of certain ages. So we would go to a health plan and say, of your women who are 21 to 65, did they get cervical cancer screening according to guidelines? Did they get it every 3 years or every 5 years if it was HPV testing? We have measures that look at chronic care. So among your members who have diabetes, is their blood sugar controlled? Behavioral health, we have measures that look at, we'll talk about depression, but here's another example, which is metabolic monitoring. If you have kids who are on antipsychotic medications, which are very powerful, are you monitoring their metabolic readings? And care coordination. So if you've been hospitalized, did you have a proper handoff that included communication that went back to your PCP? These are just examples of some of the measures that we have in HEDIS. And we think this is important because HEDIS measures are widely used. So as I mentioned, it is used by NCQA. We do health plan accreditation, so we accredit health plans based on whether or not they have the right structures in place to take care of their members and on how they do on their HEDIS measures. So it is performance-based accreditation. We also have a tool called Quality Compass, and here's where we publicly report the results of health plans and how they do on measures, by health plan, by name. You can look them up and say, oh, so only 50% of their women are getting their cervical cancer screening. And the model here is that a health plan knows who their population is, right? Because you have to enroll. And so they know their enrollees. And while people might be going to a lot of different providers, and providers may suddenly get someone who shows up on their doorstep, a health plan knows that this person is in my plan, and I can monitor to see if they got the care that they should be getting according to the evidence. And so we published that on Quality Compass. We benchmark to say that here's the average, here's what the good performing plans are getting, here's what the low performing plans are getting. It's really important. HEDIS is used in programs here in California. So the Align, Measure, Perform program uses HEDIS measures. This looks at provider organizations. It's run by the Integrated Healthcare Association. It's used to compare states in Medicaid. So this is the Medicaid core set. They have a core set for children, for adults, and for behavioral health. And it's also used by CMS in the Star Ratings program for Medicare Advantage. I mean, millions of dollars are at stake for how plans are doing on these measures. It's also used in the quality reporting system for plans who participate in the marketplaces, and many other programs. So all that is to say that we think it's really important to get measures for maternal health in HEDIS. So where are we today? So you're going to hang with me because I'm going to tell you a little bit about some data. But if you think about maternal care in terms of access to care and effectiveness to care, and the prenatal and the postpartum period, HEDIS measures draw primarily from claims data. So a health plan, that's the information they have for them, right? If somebody billed for a screening, then they can see that it happened. So they're using that information to understand whether their enrollees are getting what they should be getting. For information they can't get from claims, they usually have to draw a sample of medical records and search through that manually to see if something happened. It provides information that you can't get from claims, but it is resource intensive. But that's where HEDIS has been for a long time. And based on that, the measures that we have had for prenatal and postpartum care tended to be around, did they get a visit? Right? Timely prenatal visit. Did you get a visit in your prenatal period? Did you get a visit after delivery, within a certain amount of time? And that is really important, but it does not go far enough. And I'll say this, it's a HEDIS measure, so I can criticize it, although I'm sure my organizations wish I would stop. But, we got to go beyond visit count measures. So We have recently started pulling in more data into HEDIS in a more standardized way, and that is electronic clinical data. And it really opens up better measures for us. So we just added a measure called prenatal immunization status, and this says, among your women who are pregnant, did they get, a flu shot and a Tdap shot? Because that's really critical. And it uses gestational age as a way to specify, where the woman is along in her pregnancy, because that is critical information, right? I mean, that's something that you should track your whole pregnancy, and it really has not been required in measures that we've had, at least in HEDIS. And with that, we're able to look at better measures for maternal care, and I will tell you about these two measures in a second. But our goal is to get to relevant women-centric measures that work within the context of the U.S., which we'll talk about as well. So the prenatal depression screening and the postpartum depression screening and follow-up measures were funded by the California Healthcare Foundation and the Zoma Foundation. I just really want to thank Stephanie and Rebecca for their vision here, and really believing in us and allowing us to explore these measures, which are hard, and we'll talk a little bit more about that. They apply to commercial and Medicaid plans. They draw from electronic clinical data sources. So that means that in addition to the claims that health plans have, we are encouraging them to go out and get that information from electronic health records, case management systems, and other data that are found in a structured field, because our belief is that you should be able to pull that information without having to go and manually dig through papers. And being able to get the information in that way means that measurement hopefully is a little bit more efficient, and it can be shared back and forth. So the plan should be sharing that information back with the care teams on the ground, because as providers, you need a full picture of the patient when you are providing care. The other thing I'll point out is that it requires use of a standardized tool, because we know that a validated screening tool is important for both, making sure we detect the depression and then also monitoring. It also requires proper follow-up. So we don't want to just screen and then allow the woman to fall through the cracks. We want to see that follow-up occurred. That could be medication, it could be a behavioral health encounter. There's a whole bunch of things. So I'll just touch on these, because I think we're probably going to talk about these in our talk, and I think I'm also running out of time. But, when we develop the measures, there are a lot of things that come to light in terms of maternal care in the U.S., right? Knowledge, we have to get more information on what's the optimal timing, what are the thresholds we should be looking at in terms of screening. Policy and payment. So the fact that a lot of women lost coverage or lose coverage currently in many states at 60 days is a big problem, because the recommendations say you should screen at 12 weeks or even a full year afterwards. And it's hard for us to hold a health plan accountable when they lose their member. The health system, we want to make sure that they are connecting the information, they are touching women where they meet the system. So we all know that many times after birth, the times that you're going to see a mother is at the well baby visit, right? And so that's where we should be screening as well. And data. We need to link information between the mom and the baby so that the health plan can see where that stuff is happening and be able to track it. So thank you very much, and I look forward to our discussion.
So the biggest thing that when I have attended panels like this and kind of heard the audience chatter is sort of, so what? So like from where I'm sitting in my universe, and I know a lot of you don't live in the measurement sphere, sort of, what, so we have these measures, or what am I supposed to do from where I am? So I wanted to kind of pose to each of the panelists, sort of, given the work that you've done, what is sort of your dream for what happens, especially kind of advice to this audience, which is not, health plan management and those kind of folks, or, maybe even not even people in the state, sort of what would be your ideal for how these metrics can be used, and also what kind of promotion or whatever that you would like to see happen from the types of groups and attendees that are here today. So Christine, I don't know if you want to start.
I think just very briefly, since we have so little time, I would say that to encourage folks to think about the population level, to think about who's being left out, who are we missing, where are those equity issues, and how can we all look for opportunity to step forward and help to make that transformation in the system to make sure that we are filling in those gaps. So I think that it can really show us about the population that is not coming through our doors if we're thinking kind of at the clinical or interventional level.
So as advocates, I would encourage you to push to go beyond postpartum depression, to look prenatally consistently, to look at the postpartum period, to look at anxiety, to look at depression, and to look at PTSD. I think all of those issues look to be quite prevalent from the work that we've done in this population at great cost to probably our society, but certainly our mothers and families.
So I would say that, as providers, making sure that you are capturing the information so that we can be monitoring what's happening is really important. Working across systems, knowing that mothers go to a lot of different settings for care. And so thinking about how we can link together providers so that they are working together to care for moms and not in the silos that is really just, it happens in our fragmented system, unfortunately. It's an uphill battle. And I would say as advocates, pushing for, I was excited to see the work to extend Medicaid, covering women longer than 60 days postpartum. That is critical. And also just having the awareness around depression screening and follow-up, knowing that we're measuring out there and we really want to see it happening. And I would imagine it's probably happening a lot more than what we're seeing in the data. So.
Thank you. So an important thing that we know is that Medi-Cal pays for half the births in most states. It certainly does in California, nearing a half. So my question, and it may be primarily to Christine and Carol, but Sepheen chime in too, is sort of what do we know, especially from your data about the Medi-Cal population, such that you can comment on it, and how in particular can advocates and those in the audience sort of focus in on that really important and more vulnerable population?
Medi-Cal has decided that screening is a part of the global fee. They're not going to pay extra for it. So that means people do not have the incentive to even start by screening. So that's one thing that Medi-Cal could do, is take that out of there. And I'd also like to give a little advanced preview of a paper that we have developed, secondary analysis from listening to mothers in California. It's adjusted, comparing the experiences of women with Medi-Cal and with private insurance. And the women with Medi-Cal, even adjusting for as many factors as we could, and it was interesting, the variables that we had in our survey to do so, they're struggling with access to autonomy, respectful treatment, et cetera. So these are issues that I think Medi-Cal is going to need to really try to deal with.
I might just say briefly that I think that particularly as there's been a transformation in the system of care, to remember about the comprehensive perinatal services program available to women during the prenatal and postpartum period, and to really think about making sure that women who are entitled to those benefits are getting them, even though they might not be in a Medi-Cal plan before pregnancy. They might be on the exchange in another plan, and really not losing those benefits.
I'd love any thoughts on, we're obviously aware of a lot of inequities, especially for Black mothers and birthing people, and I'm curious if any of you have any insights. I know, Carol, from the work that we funded, we did a whole issue brief specifically on that subpopulation, which was oversampled in the California survey, but any thoughts on how using measurement can hopefully help us on the equity front, where we need to make a lot of progress?
So getting back to the comment that you made about if you don't measure it, you don't know, we strongly feel that the measures where it's appropriate should be stratified so that you're looking at how you're doing for the different population groups, and then you can turn to issues of accountability and special programs such as you've funded in California. So that's one part of the picture.
Yeah, I would agree with that. I think that and again, it comes down to data, because most people are not collecting information. We need to have race, ethnicity information. We need to go further now and look at social risk information. we just don't have that information in a standardized way. So the more we can get it, the more we can actually take these measures and look at it by these different groups to show that even if you're seeing an average of 50%, you might see a way lower rate if you are looking by, at-risk groups. And it is so critical to be able to shine a light on that.
And I think that we're really learning from the Black-led organizations who are doing work on the ground about the importance of really looking at both implicit bias and racism that's happening within the systems in which we're working, as well as the structural factors that are producing these inequities that we're seeing on the ground. And I really truly think that the only way forward is if we are inviting the women who are affected to the table to participate in these quality activities, to participate in discussions about what we are measuring, to participate in discussions about what, say, the MIHA data are saying is what's happening in the community, and how are these systems that we're working in able to partner with these women to think about how we can transform the systems that we're all operating in to better serve them. And so I think that we need to do it together in partnership and really think about changing the way that we work at every level.
I think we're out of time, so I'm sorry that we didn't get to questions, but all of us are available. I want to leave you with one thought that was really came out of the Listening to Mothers work that we did in California, and to me it's very poignant. It's what that data, and I think a lot of the other data that has been talked about up here also shows, is that women really know what they want in their maternity care in general, and what they want is actually consistent with what we know is the best care. That's both on the physical health side and the mental health side. And so, many times in healthcare, what we want in the United States doesn't make sense. Like we want, a CT scan for every little thing, and we want the high-end drug that buys you, one extra day of life for $300,000. And, there's a lot of things that we do that are a little bit, just don't make a lot of sense in terms of our demand. But this is one kind of miraculous place in healthcare where what the patient wants is actually consistent with what we know works. Midwives, doulas, people caring about each other. And our healthcare system continually does not do it. And it also saves money, by the way. So it's like just an insanity of what we do over and over again in this country. These data, certainly the Listening to Mothers survey and the MIHA survey, have a lot of very poignant quotes and things like that that I encourage you as advocates, that those are things that you can use when you are in your spaces and in your worlds to really lend voice to the issues. And there are a wealth of resources. MIHA and Listening to Mothers has a lot of issue briefs and reports and things, so I encourage you to go to some of the web links. And I hope with all of our help that the HEDIS measures will be widely implemented so that in a few years Sepheen can get up here and tell us how health plans are doing. Thank you all for hanging in there.